It's a pleasure to be here, and thanks to the team for inviting me as well. Listening to the last speaker, to Owen, in the context of what's happening in Huddersfield, it's probably a similar story, probably told by different accents and different countries, but quite a similar environment. In my presentation, what I tend to do is just give you a sense of what's happening in Ireland at the moment, and then how we've arrived at the place we're at in our journey. Just every chief executive or chief executive of trust likes to tell a bit about the history of the organisation and the stats. And we're a teaching hospital, and as Mark has said, I'm affiliated with the College of Surgeons, and we're the lead hospital for a new academic, or CSI academic group, which has been established in Ireland. There are over 35 independent hospitals across the country, serving a population of about 4 million. We're now being reorganised into a group of 4 groups throughout the country. We also like to talk about stats and numbers, and it's not because we've read 50 Shades of Grey or whatever, but we do like to talk about the numbers of beds we have and the numbers of staff, which is south of 3,000, and a funding budget of 240 million or thereabouts. And one of the things about our hospital is we've got a national centres as well, National Neurosurgical Centre and National Transplant, Kidney Transplant Centre as well. That's unique in the Irish context, because some of the national specialties are spread out amongst a number of sites rather than concentrated on one site. So we've got brain surgery and kidney transplantation, and that has its own challenges, because in the local environment we provide a local acute service. There's different probably perceptions of the organisation. If I go to the further ends of the country, like Cork or Donegal, and I communicate with people, I'll hear great stories about the brain surgery that somebody has had, or the kidney transplant that somebody has had life-changing experience. If I go to the local rugby club, which I do occasionally during the season, I'll hear about the terrible waits in the emergency room. And it's a bit like the story that was told earlier on about the cafe owner who I've read extensively about in the UK, having the dashboard on the wall about trying to get rid of those who work in the NHS. There's probably similar stories or similar passions in our catchment area about the local community service compared to the national service. So that's the environment we're working in, and that's the environment you also have to listen to as well. So it's not just about size and costs or staffing, etc. So again, on the activity, this kind of shows the environment where activity has increasing over the last 3 to 4 years, going up marginally on the admission rate. But the next slide shows, I think, the change in focus and how healthcare has been delivered across the world, a shift from inpatient care to outpatient care. And if you look at how the hospital was designed, it was designed back based on a Scottish model back in the 50s, reproduced in Cork in the 70s, and reproduced in Dublin in the late 70s. So we're actually changing the model of care, providing model of care in a completely different environment than what it was built for. And that brings its own challenges. And the emergency room, again, because activity is increasing, challenges around GP access in local communities. And again, on the outpatient side, numbers are increasing exponentially over the last number of years. Again, if you look at these figures, you'd say, why are so many people coming back to hospital as return patients when perhaps we should be managed someplace else? Our GPs tend to think that we hijack their patients and keep them forever. And that's some things around poor decision-making when it comes to managing patient care. And the fact we're a teaching hospital, I think people feel we get to the patient and move them on to bring them back in a year's time and somebody else can review them. Another challenge. But I think this slide is quite significant in the story, and it tells as much the story about Ireland as a country as it does about the hospital. Here you will see our allocation, our spend dropping dramatically from almost 300 million down to below 250 million in that 5-6 year period. And that represents a 2 billion cut in healthcare spend in that period of time. And that's linked back into the economic downturn in the Irish context. And when you look at the previous slides, you will see that we've actually increased activity and throughput through the organisation. So, when people look at that, in the context of cost reduction, there's over 17% reduction. And that's outside pay costs as well. There's been about 15 to 20% reduction in income from individuals. So we're also working in an environment where staff have seen a significant cut in their pay in that period of time. Some would say they're still lucky to have jobs. A lot of others don't. There's over 250, 300,000 people on the unemployment register, representing about 10% of the population. So we've got a significant challenge that we're working in. And one of the other challenges we have is that our population is ageing. And unlike the UK, where you've got mandatory access to long-term care, our hospital tends to have to hold on to those patients who can't afford nursing home care. And out of our beds of about 800, we've over 100 at any one time who should be in a different environment. And that brings different challenges, particularly around the safe care that patients get in that environment and exposure that they have to infections and I suppose also deterioration in a healthcare environment that's not appropriate to their needs. So we look at that figure again at 10 million money that could be spent very differently. Again, just briefly on the human resource side, again, a significant number, about 400 people less than we had 5-6 years ago. Again, with new services moving on site, particularly the cancer services which are being developed. So all in all, you've got an organisation that's been challenged both in terms of the demand on services, but also in the funding and the resources that are available to run it. But it also kind of created a burning platform as well for us, to use the euphemism from the literature. And we knew that something different was needed. And the board had commissioned a report which also had been recommending improved working relations between clinicians and management. And that's one of the difficulties in the healthcare environment. People tend to work in silos. Doctors in their own group, nurses in their own, management on their own, support staff on their own. And nobody looking at the journey of the patient and how the patient moves through the organisation. We look at the patient moving through the silos and the sections rather than us looking at how the patient's needs are. So there was a need for greater integration across the organisation, and also our decision-making processes were quite archaic. They're quite bureaucratic. Again, as Owen referred to, hospitals tend to be quite bureaucratic. They emanate from a military-style environment traditionally, and perhaps there's a time and place where that culture operates and functions and delivers results. But certainly, when you have patients in the middle of it, it certainly doesn't deliver a good service. We had some changes around the management team. I took on the role as CEO. I've previously been the Chief Operations Officer, Deputy CEO. And to be honest, if I was the CEO then, I probably would have fired myself because I probably wasn't being very effective. And I think the journey over the last 5 years, probably, if it had happened previous to that, probably meant that the organisation would be a lot more healthier than it was in recent years. Legacy issues around excessive waiting times in A&E, long waiting lists for outpatients, and long length of stay compared to national and international norms. Routine procedures were taking 8, 9, 10 days, which internationally might take 5 or 6. But at the same time in the organisation, there was a desire to do things differently. The workforce had stabilised to some extent. Previously in Ireland, there was a lot of migration from the country, or immigration, for people wanting to go abroad for new job opportunities. We actually had a high turnover of staff, but in recent years that's obviously been reduced significantly because there's been embargoes on recruitment across all health service providers. So the workforce, I think, wanted to do things differently, and that was a nugget that we actually had to hold on to. We figured out a number of things. We did know that there was an absence of shared understanding and the language about change. We all had different views of what the language was. And it's no different than delivering healthcare. Change management is a science in itself. But we all think we know what it is, and we learn from our own experiences. But there's actually a lot of work done out there and published which can be of value. So we decided not to reinvent the wheel, but to create a shared understanding and shared language that we'd use in the organisation. Well, the other issues that we talked, Owen mentioned about shared values and beliefs, and I agree. You spout the words very easily. You can say shared values, shared beliefs, but what does that mean? And we did some work around the whole area of dignity and respect. We actually did some workshops with staff from different areas to get an understanding of what was going on, particularly areas where there were some staffing challenges. And we also listened to the voices of the patients who were using those services. And we created a template of storyboards of people's experiences, both staff and patients, and replay that back to the staff, anonymised it, and used it across the organisation. And the learning from that was incredible, because the variation of behaviour from department to department, from individual to individual, was incredible. You could not believe that people coming in the same door to work in an organisation could have such different experiences depending on where they worked with and who they worked with. And by naming that, we actually began to highlight where there was bullying going on, where there was abusive behaviour, and put a language around putting in zero tolerance of that type of behaviour, and rooting out people who participated in that behaviour. And that was significant, because staff then began to believe that there's something different here. It's not another initiative, not another technique that we're talking about. I fundamentally believe that learning and development is important, particularly in downtime, because the first thing to go is learning and training and teaching and courses and conferences. And it's the time you need most of it to sustain you through the challenging times. So I had a major battle with our Director of Finance around spending money on training. We weren't spending very much on it in the first instance, but the much bit we were spending needed to be spent. So I stuck to my ground anyway, and eventually pulled rank and said, look, this is staying. And it has been a significant contributor to what I'll show in a few moments. But sustaining the training and development across all levels was important, and actually having it in a multidisciplinary environment as well, not just training doctors and training nurses, but actually having shared learning. And that approach actually led to us establishing an MSc programme in organisational change and leadership development with Dublin City University and the Royal College of Surgeons. They both had their own courses on MSc programmes, but one was focused on business, the other was focused on healthcare. But we need both, because I think healthcare is as much as a business as the other way around. So we end up having, which is unique, I suppose, to have actually two separate universities providing a shared programme. You can imagine the tensions getting that together. But it's there. We're now in the second programme. We've 25 went through last year, less than 25 went through last year, and another 20 are going through at the moment. And it's a 2-year programme. The programme is action learning focused. So the work that people do on the programme is actually links back into change within the organisation to take specific change projects. Again, so that began to develop a leadership forum within the organisation. Young leaders who will be there long after I and the other members of the management team are gone. Because again, you want to sustain change for the long term, not for the short term. It's not around a CEO's vision, it is around an organisational vision. The culture, again, there's different sayings about culture, and this one I picked up. It defines everything. It's like the water fish swim in. We're not aware of it because we're in it. And you have to stand back from your organisation to understand what the culture is. And sometimes when you hear those stories, you really get to understand the organisation. When you get out and about the organisation, I hear things. When you take off the shirt and tie and put on the short sleeve shirt, sorry, I was going to say something else there, but you get a sense of what the organisation is about. You get down to a level to talk to people and hear what's going on. I created a number for that, particularly safe places for people to come and meet me. 20 people once a month, randomly selected from across the hospital, no managers up there, no immediate managers present, but they could be managers, and to hear what are their issues. And that was, I do that every month, so over a year you get 250, 300 people's views and to get to know you. Apart from walking around, you also get to know what the real issues are. So that's been very helpful for me. The other issue, I suppose, in learning is that it's been aware of the whole hospital rather than segments of it. And I think that's what I talked earlier on about the journey of the patient through the organisation. Some key insights from the process to date is long-haul journey. Certainly not something you can do in a month or 6 months. It's 3, 4, 5, 7 years. And I think we must remember that when we think about the Toyota model, GE, my partner worked in GE 15, 20 years ago, and they were talking about Six Sigma, et cetera, et cetera. Some of that's moving into healthcare now. But they've been doing that for 20, 30 years or more. So we cannot get that change in an organisation overnight. So somebody goes away to a conference, comes back with an idea, it's going to die unless it's part of something else. So we had a whole organisational approach using conventional methods. And I know somebody mentioned earlier on about using lean as a tool. But I see a lot of these things as a combination, as tools, as a toolkit that enables the change to happen. And that can be around project management skills, it can be around change management techniques, it can be around communications, it can be using lean as a process. There's a connectivity between them. But I think you need a combination of things. Again, you'll always hear about top-down, bottom-up. You has to be at the coalface. There's no point in sending emails out to everybody telling them what they must do next. It has to be embedded within the organisation. And the external and internal focus is important as well, because you could be doing something really well internally, but as soon as the patient goes out the door, the whole thing collapses on you, particularly a patient who has long-term care needs. So it has to be beyond the boundaries of the hospital. I just use this diagram, I'm not going to go into it. It's how we hold the whole of it together and how we connect it. And particularly around the process improvement piece and the ongoing teaching and learning. And each of those subsets have actions and work plans behind them. But it's a good visual so that people understand what the methodology is. Again, our approach to OD has been to hold it at the senior management table, So we have somebody who is a lead for it. I'm very much involved with them. It goes right up to a board of directors level as well. So you also have to have a sense that we have to be realistic about what can be achieved. Not everything is achievable. And we have to be upfront and honest about that. As I said earlier on, the staff are extremely committed and they're coming up with solutions. The work we've done with the clinical directors and developing clinical directors in the organisation, I think has also been paramount. I think you need clinicians at the front end to support you, because clinicians, I mean, we had a conversation during lunchtime about how to get clinicians to change, because they've inherited behaviours over decades, over centuries. So we can spend a lot of time working in 90% of the organisation and they'll adopt, but 10% won't. And they need that investment of time and support. And sometimes it's around fear, sometimes it's around, well, I'm a doctor, so I'm more important than everybody else. And that attitude can prevail. And patients can feel that when they come into an organisation. And you know yourselves which doctors did you go to that you felt comfortable with and which one did you not? And what was their approach? So can you imagine working with somebody like that on a day-to-day basis? So some of the changes that we're making are actually around the role of doctors and the behaviours of doctors, and particularly the leaders, that they actually demonstrate good leadership behaviour. So there are some challenges because we've got old systems and new systems being played out. We've got people who are part of the old structure, the whole bureaucracy, who are still there. It's not been that easy to move people on. We've tried to give them different roles. Hasn't always worked out because their inherent behaviour still remains, which is against the total grain of the organisation. But you have to let go of some of the decision making and let staff give the trust to staff. And moving beyond the command and control system. That's paramount. The external challenges are around the reality of the financial climate, ensuring value for money. But there's also a piece where the regulators and people in the system who set targets, they want responses today. They want casualty cleared, nobody on trolleys. So what do people do? normally, and you've learned this in the UK, we've only become involved in this whole special delivery unit performance initiatives in the last 2 years. But people try to gam the figures, to pretend people aren't waiting, to find other rooms to put them into, to classify them as different behaviours. And that's lying, as far as I'm concerned. And you'll change nothing if you add to that behaviour. So you have to really strip it back down to core values. What's acceptable? So just briefly, as part of the OD programme, we created, to deal with the burning platform scenario, we created what we call the BICS programme, which is Beaumont Improving Care and Safety. And again, it's, a slide describes what the vision, what it means, what it delivers. But I suppose one of the interesting parts was when we set up the programme, we have a project manager for it, and she starts doing the internet search for some work around lean, because they have been doing some lean processing, lean learning on their MSc programs. And she came up with Mark and Ian and Lean Enterprise, and we got the guys over. We've called them the hairy bikers since then. I wonder why, but anyway, we could barely figure out which is which. It's just the hairy bikers are here today. So, but they've become ingrained in the organisation, but not delivering the change. They've been coaching me, coaching the staff to deliver the change. And I think that's quite important, because they come in for a day or 2 days a month, check where we're at, set some targets, go away and come back. And that really puts it up to all of us then to deliver in the background. And we've a couple of the projects, and again being alluded to earlier on, the visual hospital is quite an interesting concept. And it'll probably, it's now a movement called, visualizing what's happening to your patient. But can you imagine working in a hospital with 800 patients and not knowing in one point where everything is happening to those patients? Can you imagine working in Heathrow Airport and having 800 flights landing a day and having no plan around them, and not knowing where they're coming from? And that's what we're working in. So the visual hospital concept actually creates a hub of patients, their wards, their location, the names, what's happening to them, what the delays are, what can be done to improve that patient pathway, and it's live. It's updated hour by hour by hour. Now, we could have spent millions on IT systems to support it, but it's actually a very visible system that I can go into. I actually love going to the hub, because when you go into it, you get enthusiasm from the people who work in there. Yes, there are problems. Yes, there are delays, but you can feel energy, and energy for change. And that, to me, really, when I want to get away from the desk, away from a boring meeting, I'd drop into the hub, how are things going? And you just get a sense of what's working, what's not, what you have to go back and try to make work. And that's my role. The other piece of work we did around the emergency department was improving the processing of patients through A&E. And that was like a 28-day experiment where we actually put managers from the rest of the hospital in to look at the flow in A&E. And for example, one example comes to mind was the lab manager. When he was observing what was going on, he had a 2-day shift to do in there during the 28 days. And he realised that the processes that he put in the laboratory to deal with bloods coming down to him to make his department efficient was actually causing a 3-hour delay back in the emergency room. And straight away, he just got a label, changed all the A&E blood requests, and had them fast-tracked within the lab. Very simple. But we would have spent all our time talking about the lab issue and never getting it changed. But when he saw what was going on, he was actually able to make the change. And he had the power to make the change as well. He didn't have to go and start negotiating it across different silos. He just went out, went down, made the change. And that's only a very simple example of the hundreds of changes that were made just during that process. And from that, the patient's experience is improved. Yes, they would have got a result eventually, but they waited there 8 hours or 10 hours, waiting for a blood test result to come back, which in some instances you can get within 15 minutes in walk-in labs. On the long-term care project, because I mentioned earlier on about the 100 patients, what was happening there was because there's so many patients waiting for placement in nursing homes, the whole process of getting them from to the nursing homes, the whole paper exercise and getting financial approval, selling assets, etc., we were taking something like 113 days to get the patient through the process. But again, with the visualization of it and the mapping out the steps, we reduced that to 63 days. It meant we had 10 extra beds a day to look after patients. The scheduled care project is the one we're working on at the moment, where we're looking at waiting lists and use of theatres and how they can be maximised. And again, in diagnostics, MRIs, CT scans, we have a backlog of, we do all our outpatients on Monday and Tuesday, yet at the weekends we have a backlog of inpatients needing MRIs to get out. So we were shifting that work around. But it was only when you start looking at and tearing back the pieces of the work that you get to understand that the opportunities are there. So our focus now is on how to do things differently rather than what's wrong. It's not a bed of roses. And I could not stand up here and say everything is perfect. And my Irish colleagues are in the room, even if they're not living in Ireland, will brief you that there are significant challenges in all elements of healthcare. And ours in particular. But as a CEO and as a human being, it's a privilege to be part of it. I mean, it's, to get a job like I have is, a dream, but you have to respect it and use it and deliver something from it as well. There are challenges, but I also believe that the learning and sharing is important. And, the experience we've had with Huddersfield and other hospitals is certainly adding to how we're doing things. And finally, I just leave you this quote, I think is slightly apt at the moment. The future is not some place we're going to, but one we are creating. The paths are not to be found, but made. And the activity of making them changes both the maker and the destination. Thank you very much.